minimal residual disease in NPM1 mutated AML. Definitions. One of the most important discoveries in the treatment of acute leukemia is that the presence of minimal residual disease is an independent prognostic factor for the duration of remission and survival. This is particularly true for patients with acute lymphoblastic leukemia 1.2.
The U.S. Food and Drug Administration approved midostaurin, marketed as Rydapt, for the treatment of adult patients with newly diagnosed acute myeloid leukemia who have a specific genetic mutation called FLT3. This is in combination with chemotherapy. The drug is approved for use with a companion diagnostic, the Leuko-Strat CDX FLT3 mutation assay, which is used to detect the FLT3 mutation in patients with acute myeloid leukemia. Acute myeloid leukemia is a rapidly progressing cancer that forms in the bone marrow and results in an increased number of white blood cells in the bloodstream. The National Cancer Institute estimated that approximately 19,930 people were diagnosed with acute myeloid leukemia in 2016, and 10,430 were projected to die of the disease. Rydapt is a kinase inhibitor that works by blocking several enzymes that promote cell growth. If FLT3 mutation is detected in blood or bone marrow samples using FLT3 mutation assay, the patient may be eligible for treatment with Rydapt in combination with chemotherapy.
Applications in medicine. Despite the molecular heterogeneity of standard risk acute myeloid leukemia, treatment decisions are based on a limited number of molecular genetic markers and morphology-based assessment of remission. Sensitive detections of a leukemia-specific marker, for example, a mutation with the gene encoding nucleophosphine NPM1, could improve prognostication by identifying submicroscopic disease during remission.
When we hear about a mutation, we always ask ourselves, can we follow this mutation in remission? And is this a marker for relapse? And there are mutations that are very good MRD markers, and this is, for instance, NPM1. However, with IDH1 and IDH2, it wasn't clear when they were discovered whether they would be candidates. But we now get more and more evidence that they occur very early in the area of clonal evolution, and that they are not good MRD markers. And that is due to the fact that the IDH1 and IDH2 mutation can still be present at the time that the patient is in CR, and they can be still present with a high mutational load, which means that there's no clear correlation between the percentage of blasts and the mutational load for IDH1 and IDH2. So that's why they would probably, from what we know right now, not be ideal candidates for MRD monitoring.
Pros and cons. Pros: on sequential monitoring of minimal residual disease, relapse was reliable, pre-detected by a rising level of NPM mutated transcripts. Also, mutations associated with pre-leukemic clones remained detectable during ongoing remissions after chemotherapy. NPM1 mutations were detected in 69 of 70 patients at the time of relapse and provided a better marker of disease status.
In these patients, it's all about balancing relapse risk and risks for the different consolidation treatments we have. So there are two main options. One is chemo consolidation with high-dose cytarabine. The other one is allogeneic stem cell transplantation, whereas transplant is associated with a higher treatment-related mortality and lower relapse rate. With chemo consolidation, tolerability is better, but the relapse rate is higher. And by figuring out how high the relapse risk is for different NPM1 FLT3 ITD constellations, I try to give a recommendation on which patients with which constellations should proceed to chemo consolidation and which patients should proceed to allogeneic stem cell transplantation.
Cons. Limitations of the use of this marker is the presence of somatic mutations in the genes of immunoglobulins in patients with lymphoproliferative syndromes chronic, for example follicular lymphoma or myeloma multiple, that hinders the correct hybridization of the consensus primers.
So minimal residual disease, and as many of the experts in the field have said, should be known as measurable residual disease, is trying to detect the leukemia that's left behind after your initial therapy, which is typically these days is cytotoxic chemotherapy. And obviously this is a disease that has shown resistance to cytotoxics. And so there has been a wealth of knowledge developed over the last 2 decades that shows that this is a very significant predictor of outcome. And it obviously makes sense, because when you have residual disease after your therapy, it means that this is a particular population that's not sensitive to the therapy you've just given the patient. So better identification of this population of residual disease and use of better drugs to eradicate it is the future. These drugs obviously also have to be relatively non-toxic and well tolerated by the patients, because if the patient with acute leukemia has just received several months of cytotoxic chemotherapy and they're in remission and they don't know how long they have to live, the last thing they want is to receive toxic, poorly tolerated agents for the next several months of their life. So fortunately, we now have such drugs available, relatively non-toxic, target-specific drugs that we can use in the residual disease setting and to try to eradicate it. However, all of this needs to be standardized, and in order to actually have meaningful data, we need to have large studies of these agents.
Issue apply in Ecuador. Diseases caused by malignant cells in Ecuador have increased lately. This is how this new technique helps to fight exactly with that origin. We also have that the more this is applied, there are new standards of good application with these patients.
Inside the hollow area of the bones is a spongy core called bone marrow. It is here that stem cells are produced. Stem cells are immature cells that can develop into components of blood. Red blood cells, which carry oxygen to the body, white blood cells, which fight infection, and platelets, which help blood to clot. Acute myeloid leukemia, AML, is a cancer of blood and bone marrow. In healthy patients, stem cells produce myoblasts, or blasts, that develop into mature types of white blood cells. In AML, these blasts do not develop into mature healthy cells, but rather develop into immature or abnormal cells. As the number of these abnormal cells increases in the blood and bone marrow, fewer healthy, functioning blood cells and platelets are produced. If the bone marrow is unable to produce enough healthy lymphocytes, the patient will be unable to fight infections. The cancer cells can travel in the bloodstream or metastasize to other organs in the body, where they can begin to form additional tumors. AML is the most common type of blood cancer in adults, and it can also affect children. Symptoms consist of fatigue, fever, bleeding, and bruising. Current therapy includes chemotherapy, radiation therapy, stem cell transplantation, and drug therapy. Clinical trials involving biologic therapy may be available. Your doctor is the best source of information regarding treatment for your condition. It is important to discuss with your doctor which therapy, if any, is most appropriate for you.
Conclusion. The presence of minimal residual disease as determined by quantification of NPM1 mutated transcripts provide a powerful information prognostic independent of the other risk factors.